Hello everyone, this is my squamous cell carcinoma presentation for Primary Care 1 for Frontier Nursing University. So our chief complaint is a sore that is not healing, getting larger, also itches. History of present illness: William is a 60-year-old Caucasian male who presents to the office reporting a red, scaly sore on his chin that he's had for 2 months. He states the area is mildly painful, aching, non-radiating, and rates the pain as a 2 on 10. Denies fever, chills, weight loss, or drainage from the area. Denies alleviating or aggravating factors. He does state that he tried a topical hydrocortisone cream for a week without improvement. He was diagnosed with actinic keratosis over a year ago. He did not receive treatment. States he works outside times 25 years and does not wear sunscreen. A review of systems: he denies a fever, chills, weight loss or weight gain, changes in appetite or sleeping patterns. He denies tinnitus, hearing impairment, vertigo, visual disturbances, nasal discharge, sinus pressure, epistaxis, dysphagia, or enlarged lymph nodes. Denies any chest pain, pressure, palpitations, syncope, edema, dyspnea, or activity intolerance. Denies shortness of breath, wheezing, coughing, hemoptysis, or a history of lung disease or infection. He denies difficulty ambulating, balance problems, numbness, tingling, headaches, or alterations in memory or mental status. He does report the red scaly lesion on his chin that he's had for 2 months with intermittent bleeding and the history of actinic keratosis. He denies a history of cancer, known blood disorders, or genetic abnormalities. Denies suicidal or homicidal ideation, anxiety, depression, mental illness, or substance abuse. For past medical history, he did have the actinic keratosis in 2015 he was diagnosed with. We referred him to dermatology for follow-up, but he did not follow up. He has a history of hypertension, which we diagnosed in 2011. He's well managed with metoprolol XL, 25 milligrams daily. He has no known drug, environmental, food, or latex allergies. The metoprolol is the only medication that he takes. He denies any illness, hospitalization, surgeries, transfusions, or psychiatric history. Denies a family history of skin cancer or actinic keratosis. Denies alcohol, tobacco, or substance abuse. He does work for the town of Colony Public Works, and he states that he's often outside. He resides with his wife of 30 years. On our objective exam, he's a well-appearing 60-year-old male, pleasant, alert, answers questions appropriately. His vital signs are normal. Blood pressure is 122/84, pulse is 68, respiratory rate is 18, temp 97.8, and his O2 sat is 99% on room air. He denies pain at this time. His height is 6 feet, he weighs 175 pounds, and his BMI is 23.7. Our objective exam showed the 1.25 centimeter firm, asymmetrical red-tan crusting lesion to the chin. It has an irregular border and it is tender on palpation. He had no swelling of the lymph nodes. His vision was normal. His HEENT exam was normal. Cardiovascular regular rate and rhythm with no murmurs, rubs, or gallops. His lungs were clear in all lobes. No adventitious breath sounds. His neuro exam, it was alert and oriented times 3. He was appropriate. His GCS was 15. Cranial nerves 2 to 12 were intact, and he had an appropriate affect and speech. His diagnosis, which would require a biopsy, was squamous cell carcinoma. This is defined as a malignant tumor that arises from keratinizing cells of the epidermis or its appendages. This usually occurs from excessive unprotected skin exposure to UV rays, radiation, chemical, or thermal burns. It is the second most common skin cancer. The first most common skin cancer is a basal cell carcinoma. This accounts for about 80% of skin cancers. Squamous cell carcinoma is the second most common, accounting for about 15% of skin cancers. And malignant melanoma accounts for about 5% of skin cancers, but usually it has the highest mortality rate. The pathophysiology: Epithelial damage occurs from the UVA, UVB rays, radiation, burns, recurrent skin infections, or disease, and then this causes damage to the epidermal keratinocytes, and then neoplasms occur. Risk factors for this: exposure to UVA and UVB rays, radiation, arsenic is another one. Males are 2 to 3 more times more likely to have squamous cell carcinoma than females. People with fair skin, light hair and eyes, so your blondes, redhead, blue-eyed people, family history of squamous or basal cell carcinoma or malignant melanoma. If the patient has a personal history of actinic keratosis, a precursor lesion, or skin infection, the actinic keratosis has between 1 and 10% chance of becoming squamous cell carcinoma. So if this is seen in primary care, the patient is at a higher risk for the squamous cell carcinoma. Living in sunny areas such as Florida, California, arsenic exposure, and age greater than 50. There was over 2 million cases in 2010. The most common symptom that the patient will present with to the primary care office is a lesion or an ulceration that has not been healing. It may be growing in size. Some patients report that they are painful, others report that they are painless. Borders that are poorly defined. They may bleed with minimum manipulation, and they can present as an ulceration or a wart. Your differential diagnoses would be basal cell carcinoma or malignant melanoma. A biopsy would be the way to confirm these. Diagnostics biopsy, they will do a shave or punch biopsy. Some offices have this available, but most of the time the patients are going to need referral to a specialist or dermatology. Lab tests, the histopathology from the biopsy, and referring them to dermatology, surgery, or oncology. Patient education. Stressing the importance of follow-up is crucial. Once we refer them to dermatology or oncology or specialist, we need to make sure that they definitely are following up. Instructing them to report any skin changes if the area is getting larger, if it's bleeding. And the prognosis for this is usually good as long as they're primary lesions. If it's a secondary lesion, the prognosis is usually not as good. And teaching the patient to reduce the modifiable risk factors. Tell them to stop smoking, avoiding UVA rays, UVB rays, radiation, any occupational exposures they may have, and make sure they use an SPF of at least 15 every day. Things to identify if the patient is at a low or high risk. It would be a higher risk patient if they had a greater than 6 millimeter lesion on a mask area, or a greater than 10 millimeter lesion on other areas of the face and neck. So the mask areas are your chin, your eyelids, your brows, your nose, your lips, and your ears. Now, our patient in this case study would be at high risk because his area is on the chin and it is greater than 6 millimeters, and that would be considered a mask area. If patients at a higher risk, if it's a recurrent lesion, if they have an impaired immune system from an organ transplantation or from HIV, if they're still smoking, if they have a neurological impairment, if there's border irregularities. This is a photograph of the different areas on the face. You can see the mask areas are in red and the other areas of the face are in blue. There's a pencil here because the 6 millimeter lesion is about the size of a pencil eraser, and that can just help you identify that. Health promotion, teaching the clients to self-examine their skin every month and teaching them the ABCDE characteristics. So these are red flags for skin cancer. If they have a lesion that's asymmetrical, that has border irregularity, that is having color changes, a diameter greater than 6 millimeters, or is evolving. If they have a history of skin cancer, they need to follow up with a dermatology or a specialist every 3 to 6 months and have a skin exam done. The U.S. Preventative Services Task Force in 2016 reported there was insufficient evidence to advocate for or against screening. Disease prevention, the number one thing is avoiding prolonged exposure to UV rays, especially during peak hours. So instructing the patient to avoid the sun from 11 a.m. to 2:30 p.m. Using a full spectrum SPF greater than 15. So the SPF needs to protect against both UVA and UVB rays. They need to avoid tanning beds or tanning booths. Taking protective measures if they're out in the sun, making sure they're wearing hats, long sleeve shirts, long pants. They do make clothing with a UPF now, so that might be a suggestion for the patient. A healthy diet. There's been some research that's shown a diet high in fat will increase the patient's risk for skin cancer, and smoking cessation. Treatment guidelines. Pharmacologically, there are not a lot of treatments for squamous cell carcinoma. They do use nicotinamide 500 milligrams twice a day for a year to prevent the reoccurrence, and the topical 5-fluorouracil. They don't recommend this for squamous cell carcinoma unless it is squamous cell carcinoma in situ or Bowen's disease. And the retinoids, beta-carotene supplements have not been shown to be effective according to Dynamed. Non-pharmacological treatment is the gold standard surgical removal with 4 to 6 millimeter margins. They have the Mohs procedure and cryotherapy. If the area is large, they will radiate it. Diet high in antioxidants. Cata and Brown did a study that showed that calcium and vitamin D may play a role, but more research is needed. It did show to decrease cancer risk if in mice. However, human studies have not been done. Occupational or physical therapy. Typically, this is not necessary. However, if the patient has a squamous cell carcinoma on their mouth that's impairing with their ability to eat, or any area on the face that's interfering with their ADLs, then a referral to occupational therapy might be helpful. This is our script and our references. And that's all. Thank you.